Yeah,
Okay,
no.
I'm sitting here with Derek Griffin, and I think I had first became aware of you on Twitter because people post about tendons, and you have some discourse with them that I've appreciated because you're questioning a lot of the maybe the dogma out there. So we got on a phone call maybe a week ago, and it
Yes.
seems like your area or your interest is a lot of the metabolic, autoimmune, kind of these other factors that can lead to a tendinopathy. So, before we get into that, why don't you tell everyone who you are?
Yeah, so thanks, Jake. I'm delighted to be on the podcast. Thanks for the invite. My name is Derek Griffin. I'm a physiotherapist based in County Kerry, in Southern Ireland. I suppose my background is in the area of persistent pain. So my both my academic and clinical interests are in the understanding and the management of chronic pain conditions or persistent pain conditions. But as part of my clinical practice, I suppose I see tendinopathy or tendon related problems in various contexts. So, like us all, I see the athletic population, so the typical Achilles tendinopathy. I'm a runner. I look after runners. I have particular interest in athletics, so I see the typical Achilles tendinopathies in that cohort. The patellar tendinopathy in the basketball cohort. But then I see tendinopathy in the context of other areas as well, particularly in the autoimmune condition. So in the last number of years, I'm working in the field of rheumatology a little bit more. So I tend to see the insertional enthesitis type presentations in the autoimmune spondyloarthropathies, so things like psoriatic arthritis. And then, like many clinicians, particularly in the private sector, we tend to see people with tendinopathy that are more sedentary. So they're not typically the athletic populations, and they'll still develop tendinopathy. So common areas would be the gluteal tendons, the rotator cuff, the lateral elbow, and I think within these groups, the clinical presentation is in many ways similar, but there's many different things that we need to consider across these three groups, both in the assessment and the management of these individuals.
Mm. So your PhD in persistent pain, why did you go into that?
I'm a bit of a physiology nerd, so the during my undergraduate studies, I really liked the neuroimmunology of pain. So I was in my very early days before I graduated, I was fascinated around the different pain mechanisms and understanding that, as I said, the neuroimmunology of pain. And I suppose then I had the opportunity postgrad to do a PhD, and because I had taken on this interest in pain, it was an obvious choice for me. And through my PhD, I was exposed to a large number of people with very complex persistent pain conditions, primarily low back pain, but mainly in the context of more multi-site or widespread pain. And I got really good experience just listening to their stories, letting them tell their stories, and just understanding from a patient perspective the actual complexity that we're dealing with. And from there on, I've just been fascinated by the whole topic. So yeah, many years later, I still have an interest in it, thankfully.
Oh, okay, the pain mechanism thing. Maybe I don't know where you'll go with this, but I think it was Ebony Rio had a paper years ago saying tendon pain is an enigma, and she didn't have there was like we can't explain it. Have you reached any thing useful that what is going on in tendon pain? Like for a while it was like inflammation, tendonitis, then it was like tendinosis, there's degeneration, and now it's like tendinopathy. Maybe we don't know what the drivers are, but it seems like is it too general to say tendon pain, or is it like are there different types of tendon pain?
Yeah,
Yeah.
I suppose that's a good question, and it's a question that continues to be debated. I think we're very clear that there are processes within the tendon that drive a nociceptive input. So, the so-called nociceptive pain is clearly a big part of tendinopathy. I'm a clinician at heart, so I tend to approach these from a very clinical standpoint. I think we can get very sidetracked on pain mechanisms, and this isn't just for tendinopathy. I think we can sometimes end up treating the pain mechanism rather than the patient. So like when a patient comes to see me with tendinopathy or whatever else it might be, I'm interested in all the various factors across the biopsychosocial spectrum. That may be load factors, it may be the physical factors, but then looking at the person as an individual, their broader health issues, comorbidities, beliefs, etc. So as a clinician, I'm looking at, well, what factors can I influence and can I bring into a treatment plan that I can change? Because ultimately, the pain mechanism means very little to me if I don't know what to do about it. I think outside of tendinopathy and things like neuropathic pain, for example, there probably is a more of a role for medication and pharmacological input. And in those scenarios, perhaps a pain mechanism based approach leads to better timely care, timely intervention. But outside of that group, ultimately we're still left with, well, what do I do about this condition? You're not treating a pain mechanism. You're really looking at identifiable targets that we can influence through our rehabilitation strategy. So that's the approach that I would take. Earlier on, I would have been trying to categorize people into, nociceptive versus nociplastic, central sensitization, this kind of stuff. But I just didn't feel that it was really enhancing anything I did clinically. It was still coming back to their story and what things I can change.
This okay, this reminds me of the subgrouping with the Achilles tendon recently. Maybe it's been in the last few years.
Yeah.
I forget the exact subgroups like activity, dominant, structure.
Yeah.
So are you is there anything you're at odds with there? If you're like you're not really a fan of the grouping, it's more like the person in front of you. Yeah, where do you stand with that?
Yeah, that's an interesting question as well, and it's one that I've kind of tried to grapple with. I like that approach because it at least gives us insight into that there's actually multiple factors involved in something like Achilles tendinopathy, and the paper you're referring to is the JOSPT paper, maybe last year, maybe the year before. It was in a cohort of individuals with an Achilles tendinopathy out of Professor Karen Silbernagel's group, if I'm
Yeah, that
remembering
was it.
if
Yeah,
I'm
that's it.
remembering
Yeah.
correctly,
Yep.
and they broadly classified people into, activity dominant, function dominant, structure dominant, or psychosocial dominant. Again, I suppose it is an attempt to kind of, bring people into under the one umbrella. I think as a clinician, though, what you should take from research like this is that there are multiple factors at play. So again, look at the individual. They don't have to fit that particular subgroup, but that it isn't just about the structure or it isn't just about the function. We have all of these other factors that are at play. And what that showed nicely was that these various subcategory of groups had a different trajectory in terms of their outcomes. So again, if I remember correctly, the structure dominant group and the psychosocial dominant group had a poorer outcome across multiple outcomes compared to the other two groups, which we would kind of, hypothesize based on the characteristics of those groups. So again, that research tells me that everyone is not the same, but I'm a big believer in even individuals more than subgrouping per se.
Yeah. The so I'm always curious. I guess we're gonna get in the weeds with tendons, but I talked to Gerard McMahon. I don't know why
Mhm.
it came up recently, and I was on a podcast, but I was like, when I learned about tendons, it was like a paragraph of information when I was in undergraduate and graduate school. It was exercise physiology though. Um, where were you when you first got in? Like, I'm thinking you're at the point you are now, the way you view tendons. How did you develop this knowledge base or this philosophy around tendons? Like, did you start out kind of just clueless and sorry to add questions on top of questions, but do you look at tendon pain kind of similar to all of these musculoskeletal types of pain? Is there anything like really specifically different about it?
Yeah, so I suppose my interest really just developed through the clinical exposure. When you're seeing these common problems regularly in clinical practice across the various contexts that I mentioned at the beginning, you kind of develop an understanding of the complexity that you're dealing with. So you see the success stories, and then you see the people that don't respond as well, and you kind of retrospectively look back and reflect. Well, I suppose any clinician, that's what we should be doing, and saying, well, what could I have done differently there, and what factors might I have been missing? But I suppose as because of my interest in the pain world, that has been telling us for a very long time, treat the individual. There's these multiple factors involved. And to me, pain is pain. When someone says, when they point to pain in their Achilles tendon or they point to pain in their low back, we're dealing with similar neurobiological mechanisms. Now, at an individual level, that's going to vary. If you're dealing with a very athletic population and there's a very clear load increase and they develop an Achilles tendinopathy, like we can be fairly sure that that's predominantly driven by something in the tendon, in the tissue. There's something that the tendon isn't happy about. So I'm not saying that all of these other factors are always relevant, but when I'm treating somebody with tendinopathy or I'm treating with somebody low back pain, the common denominator is that I'm treating a human being, I'm treating a person with all of these, these other factors that are going on. And for one individual, they might be very irrelevant, and for another, patient, they might be very relevant. So when someone comes in and they've had an onset of an Achilles or patellar or gluteal tendinopathy, or symptoms that suggest that this is the diagnosis, I'm interested in what changed around the time. What was the context of the development of that pain? So was it just a clear mechanical change in terms of their loading patterns, or was there a change in their lifestyle? Did their sleep take a hit for some reason for the last week or two? Did their training increase? Did they have an illness? Was there something else going on that kind of set the petrol, so to speak, and somebody then you throw the match and and suddenly the tendon is now sore. So again, it does come back to the individual in front of you. I don't see tendon as any different than that. There may be an argument that the pain mechanism is more driven by the tissue and by more peripheral changes. But ultimately, it's less relevant to me than what the patient tells me and what I can change. So what factors probably led to it, and then what can I do about that going forward?
Yeah, the you said earlier on that paper. I guess I don't remember that part, but the structure dominant. So like I think they had a very poor tendon structure through, I don't know,
Yes.
was it ultrasound maybe? And
Yeah,
then
I
the
can't remember
cycle.
the details, but yeah, there was some
Yeah.
objective measure of the tendon structure, presumably ultrasound. Yeah.
So yeah, the structure dominant, the psychosocial dominant. You said they had worse outcomes compared to the activity dominant. What
Yeah.
was the other one? I forget what the other
There was
was.
I think there was an activity dominant, a function dominant.
Oh, okay.
I think they separated those. They had the different characteristics of the groups that I'd have to go back and read the read that paper, and then the other two were psychosocial and structure dominant.
So you kind of said you kind of the worse outcomes, and that's kind of to be expected. Why do you think that that's kind of to be expected that those people
As
would
I
have?
suppose, structure is a difficult thing to change. If we assume that that the structure is the driving factor in terms of their pain, then we probably need to be more specific in terms of our loading protocols if the aim is to influence the tendon structure. And I know, look, you've had fantastic guests on that are the real experts in terms of the tendon mechanobiology and how it responds to load and the different types of load and isometric versus concentric versus eccentric and the different types of strain patterns that we see, and the type of strain necessary or the magnitude of strain necessary to induce a tendon adaptation. So perhaps in that group, it's a question of how effective are our interventions at changing that structure. For how long do we do that? If we gave them a longer time, would that adapt more? Now they did still improve, but just at a slower rate than I think the structure dominance took just longer to reach a clinically important improvement in their primary outcome measure. So they still got there, but just a longer in a longer duration. And perhaps the psychosocial group, going back to what I said initially, are we targeting the drivers of their symptoms? So if I think that particular group had higher levels of fear avoidance, but it was less about the structure. They didn't have any significant structural changes. So if your intervention for that group is an exercise program that's designed to change the structure, and we're not addressing the broader factors that influence pain, then perhaps that's why we're not seeing the outcome that we'd like to see in that group. I'm assuming here, but that would be my educated guess as to why we're seeing poorer outcomes in that group.
Yeah, that makes a whole lot of sense. So when we look at this tendinopathy thing, kind of as a just an overload, overuse condition, you've exceeded the tendon's capacity. Do you think that's accurate to just bucket all the tendinopathies into this? You did too much too soon, and that tendon's flared up.
Yeah, I think it's often a very clear mechanism of pain onset. So I think we'd be naive to think that it isn't important or it's not relevant across a large percentage of people that present with tendinopathy. I suppose how much you get away with changing your load is dictated or at least influenced by a lot of other factors that we might not consider. So, in our informal chat last week, I spoke to you about this kind of buffer zone. So it's basically people that are generally fit, active, healthy, they may have a larger buffer, meaning that they can get away with a little bit more before that tendon says, I'm not happy. Whereas in other groups where they may have more complex risk factors, so we might discuss the role of kind of metabolic, endocrine, more systemic risk factors for tendinopathy. In that group, then a very subtle change in load may drive that tendon response and drive the pain. So you can look at that both ways. You can say, well, it still was the load that resulted in the tendon change, but the load was often so small that, normal changes in daily life that daily life require means that this could potentially happen again, or, it's likely to happen. So we would, in that situation, I'd be very keen on addressing or at least acknowledging these other factors in addition to any exercise intervention that I might give the patient specifically to enhance the health or function of the tendon. So I think the exercise bit is important across all of these groups, but it's this broader context as to, why did this develop and was that change in load, would we consider that to be a significant change in load to induce a tendinopathy, or was it so subtle or so small that we need to be questioning, well, why did such a small magnitude of load result in this problem? And that's when I would look at the broader systemic factors that might be at play.
Yeah, I just this morning I had a call with a guy. I think he's 36, and well, patellofemoral pain, but I guess we kind of bucket into an overuse issue. And he changed his training from 3 days a week lower body to 4 days, and I'm like, I'm pretty sure that was the based on everything else. I'm like, that's probably the
Yeah,
thing that set it
yeah,
off. I think it's age though, because I was having that talk with him. I'm like, if you were 16 and you did this, you'd probably be fine. 16 years old, you make a small change in training, you're probably fine. But now you're
yeah.
36, you're kind of getting to that age. Do you think outside of well maybe that is part of the metabolic things because maybe general health just goes down when you get 30, 40. um what do you think it is when you start to reach these higher ages, you make a subtle change in training load and you're so sensitive to some tissue blowing up? Do you think it's metabolic issues? What do you think it is?
I think it can be. I suppose as we age, there's probably more scope to develop some of these systemic risk factors. I suppose some of your previous guests might be able to give a better explanation, particularly in terms of the structure of the tendon as we age. I think as it kind of makes a little bit of intuitive sense, at least that that we get away with a bit less as we age, so we need to be a little bit more sensible with our loading. So there probably are factors specific to the tendon, but again, the tendon health has to be considered in the broader context of overall health. So how sleep changes throughout the lifespan, as people change jobs, family roles, etc. Particularly in non-professional athletes where they're kind of juggling many different things, and they've been out of fitness for a while and they want to get back into fitness. So there's this sudden increase in load on the background of being sedentary for quite a while, and maybe have put on a little bit of weight, maybe have developed, other risk factors around sugar levels, pre-diabetes, that kind of stuff. So I think it's a combination of factors, and in some situations it's just the perfect storm for a tendon. So there's a sudden change in something on the background of having done too little for too long.
Yeah, yeah. Okay, so if we talk about these, okay, I think it's been maybe just a year or two for me because I'm pretty looking at attendance now for like 5 years, but the metabolic stuff I've really been coming up for me recently. That and the things, one research paper was kind of like high blood sugar, high cholesterol, high blood pressure. I don't know what the other one was, obesity, just
Hmm.
inflammation, whatever.
Yeah.
What are is there too many to list? What are all the metabolic factors that can go into someone's like this buffer zone kind of decreasing? Yeah, what are these major metabolic factors?
So I suppose the well documented ones would tend to be things like diabetes, obesity, and hypertension and high cholesterol. So I suppose collectively termed the metabolic syndrome. And these conditions often coexist with one another. So they somewhat, they often have shared mechanisms as to why they increase the risk of tendinopathy. And look, as a clinician, I'm not an expert again in exactly how these factors influence that, but I think broadly we can say that they have an effect on the collagen structure. So, take diabetes, for example, the sugar molecules will interact with proteins in the tendon, leading to a process what we call glycation. And there's some end products of glycation that ultimately increase cross bridging between the collagen fibers and make that tendon a stiffer tendon. We tend to see collagen disorganization, and then we see negative effects of these conditions on the cellular response. So, say on the tenocyte response. So we know tenocytes are very important to maintain the integrity of the extracellular matrix and the structure of the tendon. So, the adaptive ability of the tendon becomes impaired. So the tendon becomes easier to overload. And when it is overloaded, it becomes much more difficult for that tendon to adapt or to heal in the context of an acute tear, for example. And this is common across various tendons. So we see it in the Achilles, we see it in the surgical literature around rotator cuff repairs post-surgery, that people with things like diabetes have poorer healing responses. And of course, even outside the tendon, we see this, just the healing of people with these comorbidities is poorer than if they didn't have these conditions. So yeah, diabetes, hypertension, obesity, and I suppose another mechanism by which some of these factors might influence the tendon is that they're generally pro-inflammatory. So the metabolic syndrome is associated with an increased in the low grade inflammation or systemic low grade inflammation. So these are driving pro-inflammatory changes that are long term probably not very healthy for the structural integrity of the tendon. But even moving away from the tendon, we know that these risk factors are also risk factors for pain in general. They're risk factors for just musculoskeletal pain in general, which is often why, tendinopathy will often present in the context of multi-site pain, or you may have multiple tendinopathies. So you kind of have this tendinopathic pain presentation. So they may have an Achilles, or they may have a, plantar heel problem, but they also have a grumbly cuff-related shoulder problem, and they may have a history of lateral elbow tendinopathy. So you kind of get a picture very quickly that this person is predisposed to tendinopathy or to tendon-related changes at multiple parts in their body, and then you're looking at, well, why might that be? And I suppose that's when you go deeper into these more systemic risk factors. Outside of that, we see hormonal changes can be linked to tendinopathy. We see an increased rate of tendinopathy, for example, post-menopause or in, perimenopause, and this is where we typically see things like lateral hip pain, lateral gluteal tendinopathy type presentations, and then in endocrine disorders, so people with thyroid related issues. So that's just the broad categories. That's just what we tend to see commonly. And I suppose if I were to summarize, I'd say they have an effect on the structure, so on the collagen structure, so a bit more disorganized, less adaptive, less responsive. They're pro-inflammatory. Things like hypertension can have an effect on, and diabetes can have effect on the vascular pathology, which again will influence tendon health to a certain extent, and they're pro-inflammatory. So a kind of combination of various mechanisms predisposing to a tendon that's less adaptive, less responsive to load, or narrowing the buffer, as I said, and then less responsive or adaptive to that load in the first place, as well as generally increasing one's risk of developing musculoskeletal pain.
The vascular thing, is it just worse blood flow from the diabetes and the high blood pressure?
Yeah, so I suppose we know that people with things like diabetes are much more at risk of things like peripheral arterial disease, changes in the microcirculation. So yeah, my very layman's knowledge of that is that it's just having some negative effect on the blood supply or the blood flow to whatever tissue that we're dealing with. So beyond that, I'm unfortunately not a not an expert to give you any more info on that.
Yeah, that's what I read on that metabolic thing. That I think they had an infograph with the hypertension, and it was just like I think their explanation was lower blood flow.
Yeah,
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 probably. I mean, and then that would support the healing response. You need blood flow for a healing response, and if you're having less blood flow,
yes,
probably going to
yeah,
take longer.
yeah,
This whole thing with the multi-site pain, I think maybe I'll let you talk about the lateral hip thing. You said the lateral hip tendinopathy is one of those where it's rarely just like an isolated event, but it's like I guess in other areas. What's going on there with like because we think of the tendinopathy. If I think of the lateral hip tendinopathy, oh maybe you overloaded the lateral hip, but
yeah.
yeah, yeah, go ahead.
So I suppose it's really just out of clinical experience. I see this. I rarely see something like lateral hip tendinopathy in particular in the context of single site pain. So, when you ask these people around pain in other sites of their body, it's quite common that they will report things like low back pain or again shoulder pain or knee osteoarthritis or for example, not limited to those conditions, but generally get a sense that they have multiple sites of pain that are bothering them. And we're probably dealing with some sort of shared risk factors. So, we've alluded to some of them in the case of post menopause, changes in estrogen levels. So there may be hormonal influences. Midlife is a time where you'll see changes in people's weight. So men tend to put on more abdominal mass and women tend to put on more weight in the pelvic area. And again, we know the influence of an increased BMI on tendon and musculoskeletal health. It's a time where we see changes in sleep patterns, changes in, it's around the lifespan and changes that happen around that particular time in our lifespan. And the way I would see this is that all of these changes predispose to pain in general, not necessarily just influencing tendon health. So what we tend to see is this spectrum of conditions. So, again, if you look at the research on osteoarthritis at the moment, we see very strong parallels with tendinopathy, particularly in relation to the metabolic health side of things. So we're suddenly realizing that there's commonalities across these various diagnoses, and that there might be specific things to each of the diagnoses, but there's a lot of things that are shared across them. So when it comes to the etiology and I suppose the reason why people develop these conditions, it's again pointing us towards these broader biopsychosocial considerations that we need to be probably a little bit more in tune with than we traditionally were with these very specific so-called kind of peripherally driven conditions like osteoarthritis or tendinopathy.
Hmm. Um, to kind of sidetrack here, it just came to me. Fluoroquinolones.
Mm,
What are your, we never have talked about this, but it's one of those things where I'm like just known to be associated with tendon rupture, tendinopathy. I guess if someone's
yeah.
sensitive to it, what's exactly going on there?
Yeah, like it is out there. It's not that common. I suppose it depends on the setting you're in, how much of it you'll see. So fluoroquinolones are a particular group of antibiotics that are in common use to treat various types of infections. So it's definitely something that the clinician working with athletes needs to be very much aware of. And it's not just in athletic populations. I suppose the fluoroquinolone induced tendinopathies that I have seen are often in non-athletic populations. I'm not actually aware of the literature in terms of the side effects. Is it more common in athletic versus sedentary, or does it differ in that regard? But it's unfortunately a negative. It's an adverse effect, an adverse reaction of this particular group of antibiotics. So it's just routine now, or it should be routine when you're dealing with somebody, particularly with sudden onset. So fluoroquinolone induced tendinopathy tends to be a lot more aggressive and a lot more sudden from the ones I've seen, and unfortunately can lead to very serious the serious side of the spectrum. So we'd see, Achilles rupture being the typical example. And if I'm correct in this, again, I'm not an expert in this area, but it tends to affect the Achilles tendon more than other tendons. I'm not sure why that is. Perhaps I suppose that the Achilles tendon gets the most load from, we're all using that on a daily basis I don't know how that interacts with the antibiotic itself. But I'm not aware of the research on the other tendons and how that's affected by fluoroquinolones. But especially in the setting of somebody that presents with a sudden onset bilateral patellar tendon, or not patellar tendinopathy necessarily, just lower limb tendinopathy, then where one of the screening questions is, have you had any recent use of antibiotics? And if they don't know the name, then they need to tell us the name, so they need to get that. It'll generally have SIP or flocks in the name. So if you see that, then again it should raise alarm bells in the right context. Yeah, so I haven't seen many of them. I have seen it in the context of an Achilles rupture, but thankfully it's not all that common. But definitely something we need to be aware of.
Yeah, I've talked to a few people that have taken it, and then well, quad tendon guy comes to mind, but I don't know. I don't know if that's the cause. I took it many years ago and dealt with tendinopathy ever since, and it's like, it
Yeah,
would probably take a long conversation to figure out the exact story.
yeah.
When he talked about the multi-site pain, I've talked to a number of people who've had like tendinopathy all over their body, and they're healthy. Well, they seem seemingly healthy, younger people. What does that tell you, or do you need more of a story when someone has like this multi-site tendinopathy all over their body?
Yeah, I suppose what we haven't discussed yet, and it's a very important topic of discussion, is the potential for autoimmune driven insertional tendinopathy, or what you'll see termed as enthesitis in the research. And enthesitis is a hallmark feature of certain types of autoimmune conditions, particularly the group of conditions that we refer to as the spondyloarthropathies. So the typical ones that I would come across would be things like psoriatic arthritis, which is a type of autoimmune arthritis that people with skin psoriasis or history of psoriasis develop. And you always need a bigger story, of course, but if someone is coming in with multiple sites of insertional tendinopathy, which they generally all are, except for the mid portion in the Achilles. Most other tendinopathy presentations will be insertional. But if someone has a strong history of insertional tendinopathy, especially when there's no clear load-inducing factor, then you gotta be suspicious of the possibility of an autoimmune spondyloarthropathy underlying this. Again, certain tendons are more prone to be symptomatic. So insertional Achilles, plantar heel pain would be very common ones, but it's not limited to that. So, there's no reason as to why a spondyloarthropathy would just present with an insertional Achilles, or, plantar fasciopathy, for example. It can and does affect every enthesis in the body, and it isn't just the tendon enthesis. Anywhere connective tissue is inserting onto bone is going to be influenced in this. So if someone has very site-specific pain only at the insertion of various tendons in the right context, and there's a lot of other things that we should consider, and we can discuss those if you want, in the broader context, then I'm looking at, is there any possibility that this could be inflammatory? So I suppose as part of my screening, because I suppose I'm just so used to dealing with people with general kind of multi-site kind of multi-comorbidities, that as part of my general assessment with everybody, regardless of whether they're an athlete or not, because I think if I do this with everybody, then I'm not missing things. It just becomes routine. We cannot assume that, and just because they're athletic, that they don't have some of these other risk factors, nor should we assume that because somebody is sedentary that they do have those risk factors. So again, I'm looking at everyone as an individual and seeing what factors might be relevant. But specific things that I would look for in the inflammatory context would be, a history of psoriasis. They may not always know they have psoriasis, so they may have attributed it to dry skin, or they might have, called it something else. But when you examine them, you need to be vigilant of skin changes. I'll generally do a nail assessment with everybody. So psoriatic nail disease is particularly, it's a risk factor for the development of psoriatic arthritis. So you're looking for specific types of nail disease, things like onycholysis, which is a lifting of the nail bed, or nail pitting, which looks like small little indentations in someone's nails. And they're not going to, the patient might not tell you this because they may have had it for so long that they're just not aware of what it is, or they've attributed it to something else. And I suppose it's an important point to remember that the average delay in diagnosis for some of these conditions is up to from 9 to 11 years. from symptom onset. So it's a big problem. We're not picking these things up early enough. And that really matters because the earlier the treatment can be started for these conditions, generally the better outcomes. So, I'm asking somebody about skin conditions. I'm asking them about any family history of various inflammatory conditions, rheumatoid arthritis, psoriasis, psoriatic arthritis, a few other bits. Other painful sites in their body, particularly joint pain, fingers, small joints of their hands and feet, any synovitis or any swelling that they've noticed, any any like response to NSAID. So, for example, if someone says, when I take my anti-inflammatory, I'm significantly better, usually within 24 to 48 hours, in the right context with the other factors in the story, then that's again suggesting that there may be an inflammatory component. Looking at any visual problems that they've had, uveitis, which is an inflammation of the eye, is a very common, not very common, but it is common in this particular group of people. So, again, asking them about any vision, any, eye soreness, eye redness, for example, and then doing a very thorough history around, again, looking for any joint swelling, looking for skin changes, asking them around morning symptoms. So you might be familiar that one of the hallmark features of an inflammatory arthritis is pain that's worse or not improved by rest and better with movement. So these people will often have very prolonged morning stiffness. In axial presentations, it'll be very much spinal, so kind of low back and pelvic area. But rather than saying, when I get out of bed and 10 minutes later I feel a lot better, they'll still be sore and stiff into the middle of the day, very often. Pain that wakes them in the second half of the night can be a feature of these things, particularly kind of low back and pelvic pain, alternating buttock pain. And these would generally come under the umbrella term of inflammatory back pain. So, if someone is presenting with tendon pain in the context of all of these other things that I've just mentioned, you then be thinking, okay, well, they're not coming in saying I've suddenly, I did some climbing, or I started some hill running, or I introduced plyometrics for my bone health. There's no clear reason from a load perspective as to why they would have developed a tendinopathy. And they have all of these other features that again I routinely ask for because it doesn't take very long and you just get very good at doing this. Then that bigger picture gives me the context as to what I need to do next, whether these people need diagnostic workup for a possible spondyloarthritis, or if it's very much a clear load induced tendinopathy. So there is a danger in the athletic groups because spondyloarthritis develops typically before the age of 45. And there is some evidence that one of the features associated with a delay in diagnosis is earlier onset of symptoms. And the way that is explained is that people assume that because they're young, they couldn't have an form of arthritis. And what we're referring to is the typical like osteoarthritis that is much more common 45 plus. But inflammatory arthritis affects across the lifespan. So right from childhood into old age, but generally these spondyloarthropathies come on before the age of 45. So sometimes why they're missed is because the person might be athletic and they may have some load-induced features of the tendinopathy. But again, unless you're asking or screening for these other factors, it's actually commonly missed in this particular group of people. So it's something that clinicians need to be very aware of because it's not rare. It is relatively common compared to other things. Yeah.
Is there, maybe you can speak from your experience, is there or research as far as like percentage of tendon pains, how many of them fall into this category? Is there anything out there on that? Or maybe
Yeah. Well,
from your personal experience?
I don't know the exact figures, but my assumption is that the majority of tendon pain will fall into the kind of the load induced kind of tendinopathy, plus or minus the more sedentary tendinopathic presentations linked with the kind of the metabolic factors. So again, if you're working with athletes, you're going to see more of the former, and if you're working with the general population, you're going to see a combination of the athletic stuff and then the more routine kind of the sedentary person that takes up a new activity and has these other risk factors, and the interaction between the increase in load and these systemic risk factors predisposed to tendinopathy. But if you're working in a secondary care setting, if you're working in a setting where you're seeing people after they've had other interventions that haven't been as successful, then you need to look at, okay, well, if I'm going to do the same as they've just already had done, why am I expecting a different outcome? So you got to be asking what might have been missed or what other factors might be driving their tendinopathy. So in certain settings, particularly in secondary care, in the setting that I'm working in, I'm going to see a little bit more of that because by the virtual nature that I'm seeing these people after longer durations of pain, then the other interventions that they haven't resolved the symptoms. So if someone comes in and they've had a very good loading program and you're still thinking, well, this isn't getting better, you know, being aware at least of these other factors is very important so that the inflammatory stuff or other systemic risk factors don't go unnoticed.
Yeah, this makes me think of the insertional Achilles. It's the same location as what you're talking about. If it's
Mm,
the yeah, so
yeah.
when I think Achilles, I'm like mid portion or insertional, and then you can find tons of research articles on loading programs, heel wedges for insertional. But do
Yeah.
you still think like this is going too soon that you don't even know if it's just an insertional Achilles or if it's the other things?
Yeah, I think look, you know, clinical practice is often a game of probabilities, and you're always listening to the story. So if someone presents and they don't have any of these strong risk factors, they don't have psoriasis, they don't have, you know, a history of low back stiffness in the morning, they don't have other joint pains, and they have a clear training increase in terms of volume or intensity, that loads the Achilles tendon and they develop an Achilles tendinopathy, I think, you know, the balance of probabilities would state that, you know, this is less likely to be an inflammatory population. But, you know, again, if it's somebody that has, you know, a relatively smaller increase in load, a little bit more subtle, they may even still be quite athletic, but they have these other risk factors, or they have no increase in load, which is even more of a red flag. So someone comes in and they just wake up one morning with a really sore insertional Achilles, you know, that should be really making the clinician suspicious of something more systemic. If there's no clear load-induced reason as to why they might have developed a tendinopathy. So, as we always say in dealing with people with any kind of complex problem or any problem for that matter, you know, the story is the key bit. You know, what was going on around the time that you developed this pain? And if we have a very clear reason as to why you developed it, and it makes sense from a tendon, everything we know about how tendons respond to load, then I think we can be confident that how to manage this. But if they don't have that clear story or it's vague and they have a history of other things that we outlined, and in the context of a good examination, so this is where you'd be looking at their other joints for signs of any swelling, any changes in the joints in terms of tenderness to palpation, all of that stuff, nail changes, all things like that, then in the right context, you may or may not be suspicious of an underlying systemic process.
So say they have this inflammatory autoimmune thing.
Mm.
What are you doing? You just referring them out to a specialist for
Yeah,
treatment or what?
yeah. I suppose it depends on what stage they're at. So you know, they may present to you as with the dominant symptom of enthesitis or tendon-related pain, and they may not have a diagnosis of an inflammatory arthritis. So in those scenarios where there's enough from the story and their clinical presentation to suggest that there may be a more systemic process going on, then absolutely, you know, these people require referral to see a rheumatologist, or at least back to their GP, who will then forward them on to see the rheumatologist for diagnostic workup. You know, in terms of how we manage it, we have very little evidence from a rehabilitation perspective on how these people respond to our typical loading program. So if you read the raw RCTs on, you know, tendinopathy, be it Achilles, particularly Achilles and patellar, you know, the vast majority of those studies are done on athletic populations. So they're done on people that don't have, or at least less likely to have these other risk factors. That you know, the people with inflammatory arthritis are excluded, and that's done for a good reason because we want a more homogeneous group. But the problem will arise is when we apply that research to the broader tendinopathy groups that do have all of these other risk factors, or it is an autoimmune process. We don't have as strong evidence as they respond as favorably. So we know that, say, in the context of diabetes and metabolic syndrome, there's been one or two papers. I believe in the Achilles, that shows that they don't respond as well to our typical loading programs. So their outcomes are poorer, which would again make intuitive sense if the tendon can't adapt as well. And in the context of an inflammatory enthesitis, they can be very challenging. So, you're going to need to combine the medication management from their rheumatologist and look at an exercise-based intervention around managing that. So, for example, in the Achilles, particularly in the insertion, they can be really nasty if they have a really inflamed enthesitis, and things like offloading it with a significant heel raise maybe more appropriate in the early stages. We don't know how they respond from a loading perspective. So if we start them on an isometric program, or the typical type of programs that we would do, they may very well respond similarly, Jake. I don't know is the answer. And I don't think it's a bad option to at least apply some of those principles that we take from, I suppose, the athletic research on tendinopathy and how we know tendon adapts. But we have to be very clear that there's an underlying systemic process involved in here. So we need, as clinicians, to be able to, again, listen to how the patient is responding, and just alter the program. There's a bit of trial and error sometimes, isn't there? If you start them with an isometric program and then, they're doing well with that or not well, depending on, change the angles, change the load, change the hold times. I'm quite open to the fact that we just don't know. And you got to experiment with these various options that we do have. But improving their general systemic health anyway, in conjunction with whatever you're doing from a tendon perspective, is always going to matter, I think.
What do you know with someone with tendon pain? I guess these autoimmune things to me seem like to me at least, seem pretty extreme. The metabolic, like the high blood sugar, these things are kind of just like maybe
Yeah,
more controllable. From
yeah.
my point of view, maybe I'm wrong there, but as far as the drugs, like people taking statins or they're taking stuff for their diabetes, do these have any effect on tendons, good or bad? Have you seen anything out there?
You mean the medications that people would take for
Let's say
things?
high blood
Yeah,
pressure, they're gonna take or cholesterol, they're gonna take statins, or for diabetes or obesity, they're gonna take some. My immediate family has a ton of type 2 diabetes, so they're all on all these plethora of drugs to try to manage their blood sugar. Um,
yeah.
yeah, yeah.
I think I think that's often a difficult thing to answer because, particularly in clinical populations, if you're looking at risk factors for, how say type 2 diabetes influences the tendon, these people are obviously going to be on, vast majority of them are going to be on medications that address their type 2 diabetes. So it can be very hard to separate the effect of the pathology and the medication. I suppose that's when we go to the basic science work. I think there's enough basic science, to my very limited knowledge of it, to suggest as to why these factors, the pathology around type 2 diabetes, or high cholesterol or lipids, and the negative effect that has on the collagen structures. I think it's quite clear that the conditions themselves definitely have a negative impact on the structure, and do predispose to structural changes and pain in general. So I'm not aware of any research that conclusively says the medication that we use for these kind of conditions in and of itself has a negative effect on the tendons. But and perhaps there is some evidence around the effect that any of these meds have out there. I'm just not aware of that. But it's, I suppose we are aware of the negative effect, particularly of steroids, for example, and they would often be used in the context of autoimmune conditions during a flare up or whatever. Some people would be on steroids for varying lengths of time. And the group of antibiotics that you mentioned, the fluoroquinolones. But I suppose outside of those two very obvious groups, yeah, it is a good question as to what the effect of things like statins. And again, I don't have enough knowledge on that particular area to comment specifically on that, Jake.
Yeah, I was thinking, I'm curious how you go about this because it seems like a lot of these, maybe not a lot, but some of them can be solved by lifestyle, or they can be improved with lifestyle. Some of these metabolic issues. I recently had a call with a guy with jumpers, and he had it for a long time, and he was a heavier guy. But I had a hard time bringing up the lifestyle thing and being like, maybe you're in a camp to try to lose some weight. I'm usually fine, but this time I was not. How does it go for you? if you're sitting in that office and you're thinking like lifestyle, the sleep, the stress, the
Yeah.
nutrition, how do you go about bringing that topic up?
Yeah, so I suppose that's another reason that I ask these questions routinely, because I think when we ask things routinely, we take away the stigma that's associated with it. So sometimes we add to the stigma by not asking them. Like if in my screening I'm perfectly confident in asking somebody about, their cardiovascular history, but I'm not happy asking them about their mental health history, I can see why that's any different. So in one regard we're trying to reduce stigma, but sometimes through our behavior and our kind of through the fear of asking these questions we actually drive the stigma, because by not asking it we kind of we're shying away from it. So I routinely ask about all of this, and at the beginning of our conversation, I'll have that conversation with patients that, these, I need to understand you, and in order to understand you and help you, I need to know, your general health stuff. I need to know what things might get in our way of getting you better. So when I frame it like that, firstly, it's less intrusive, and they just see it as, I'm here to understand them rather than I'm here to find things to blame on their pain. So I suppose that leads to how we frame it. So if I'm bringing up the topic of, weight management or whatever, you know, I kind of use the jigsaw analogy a fair bit. So it's only one piece of a bigger jigsaw puzzle. So if we look at the research, particularly in the pain world, people of all shapes and sizes get pain. It is not limited to people that are overweight, or people that are underweight, or people that are normal weight. So when I'm having the conversation with them, I'm saying to them, look, you know this is no more or less important than looking at other factors that we've discussed, whether that's calf strength or whether that's their exercise levels. So it's how you frame it, rather than saying to them, you have this tendinopathy because you're overweight. And that's very kind of, that's not the right way to do it, because you're essentially blaming them for their own condition, rather saying, look, you've ended up in a situation where you have this pain, you're not sleeping very well, it's having a negative impact on various aspects of your life, and as part of that you may have put on weight, and that's not your fault. You're trapped in this little bit of a cycle. So if we're going to change that cycle, we need to change everything about it, and it's not just the weight bit, but yeah, that is an important bit of the story. And there's also a duty of care in this. So if someone has something that's modifiable and it's potentially changeable, then I do think we have a responsibility to raise those concerns. By shying away from something that's potentially detrimental to their health. In some ways that's ethically questionable as well. So it is a difficult conversation, and there's no right and wrong. And I think you learn from your own experience how to do this. I would hope that I now have a way of doing it that doesn't come across that you're blaming somebody for their condition or their pain, but framing it in a way that, look, it is a part of a bigger jigsaw, um, that we need to find all the pieces for. You're here because you want to get better, and if we're going to do that to the best possible way, then we need to understand everything about you, rather than just your tendon or your low back or whatever it might be.
Why do you think I guess the diagnosis side of the tendinopathy, why do you think it's not the way you say it is pretty comprehensive, but from it doesn't seem like that's the case. Why do you think it's like gone away from that? It's not a comprehensive story, but it's more like, oh, you have localized pain there, tendinopathy from too much load, and people are not looking at all these other factors. Why do you think it's become like that?
Um, I don't know. I suppose there's many reasons as to why. One of the reasons is probably that people might feel that they're not in a position to address those factors. So when you can't address them, then don't ask about them. But ultimately, it's going to have a negative impact on your outcomes. So it will have this. And I suppose if you're working in a setting where you do have access to the multidisciplinary teams, you have good rapport with the GPs in the community. I think we can overcome some of these barriers. So, like, I suppose really what you're asking is, what are the barriers to good biopsychosocial assessment? So if the intervention that you have is an exercise-based loading intervention, then there's you're not necessarily going to look at those other factors that you can't really. Well, I suppose we like what we probably need to realize is that we probably have more influence on them than we think. When you look at the research on resistance training and metabolic health, it's very favorable. Um, so we can definitely play a part in that. If you're giving somebody a resistance-based program that has these other risk factors and they're from a more sedentary population, we can frame it in a way, look, this is good for your tendon, but it's also good for your general health, so there's lots of benefits for doing this rather than you need to do this in this particular way because we need to get your tendon stiffer because that's what the Achilles or the patella research tells us in this athletic group. I'm not convinced that we need to be as prescriptive. So I think as when clinicians realize is that they don't need to be as prescriptive or as recipe driven for this tendon stuff, that there is scope, depending on the patient in front of you, to be a little bit more creative with the program, to have it a little bit more comprehensive. I know, Jake, we discussed last week, does the tendon program protocol need to be heavy all the time? So do we need to be loading people heavy, relatively heavy to their baseline strength to get tendon adaptation? We probably do if the outcome is the tendon. We probably do if the outcome is to get the structural change in the tendon, but probably not in many groups if the outcome is to get their pain down and get them functioning better and get them healthier and getting them their quality of life better. So again, that comes back to what their goals are. Who you're dealing with. Is this an athlete that needs to be able to repeatedly jump and hop and run the marathon, or is this somebody that has gluteal tendinopathy that limits their ability to go on a 2 mile walk? And does it like that? That's clearly different. One is demanding a very spring-like tendon and be able to function as a spring and do all of the high level activities, and the other is not so much from the requirements are less. So if we're too prescriptive with our programs, then we're not going to meet the patient where they're at, and that's kind of my view on that.
Mhm. Um, Outside of this podcast, because I guess I haven't heard any of this myself because I'm in the athletic population dealing with tendons.
Mhm.
What do you think needs to be done? Is there a piece of research that needs to be done to make this kind of more common knowledge with the diagnosis, looking at the metabolic, autoimmune factors? What do you think needs to be done?
Yeah, so I suppose we probably need a little bit more research on the non-athletic groups for sure. Um, I suppose it might be hard to recruit for these. So you're rarely going to find, and you know this, Jake, from your work on patellar tendinopathy, you're not going to find a patellar tendinopathy in middle age, nuance it, patellar tendinopathy. It just doesn't. It's just not there. So maybe patellar tendinopathy is a bad example for some of these metabolically driven tendons. They tend to be younger age. They tend to be male dominated. They tend to be jumping athletes. So that's a particular group that we see. Maybe in the Achilles tendon, it's a little bit more mixed. We see the athletic stuff, and then we see the more sedentary stuff that they start running after years of not doing it, or they've become a little bit deconditioned and they've become, they're generally not happy with their overall health, and then they start running. So in that group, you do have the typical load bit, but then you have load on the background of other systemic risk factors. And how do we manage that group? Do they need to be managed a little bit differently than your typical high-end athlete that's a jumping athlete that's a sprinter that has developed this Achilles tendinopathy from increasing their speed work, and that doesn't have all of these other factors. So if we give those both a heavy loading program, firstly, how well do both of those groups do comparatively, and then what's the recurrence? How do we change this trajectory in the long term? If we're not addressing some of the other stuff, is one group a little bit more predisposed for this developing? So we need a little bit, I suppose the inclusion criteria need to be broader. Like we have seen it a little bit in the LEAP trial, the gluteal tendinopathy group, this is not necessarily going to be from an athletic population, so it's nice to see some work and positive findings around that. The rotator cuff tendinopathies, again, a very mixed presentation of athletic people that develop shoulder issues versus, the vast majority of rotator cuff tendinopathy that I see is in a more of a sedentary, non-athletic population. And if you look at the research on rotator cuff tendinopathies and you look at the various exercise interventions that that work or at least look like they're effective for this group, they're quite different than the interventions that we would see in the lower limb for an Achilles. And why is that different? Is it because the rotator cuff is performing different roles versus say that's something like an Achilles tendon, or are we seeing a different group of people in terms of one is very typically athletic Achilles tendinopathy where there's a sudden increase in load versus a shoulder that's more driven by these other systemic risk factors and the loading bit of the equation from a rehabilitation perspective. Does it have to be as precise or as because you're dealing with two different groups of people that need to get back to different types of activity? So the question is, where are they now, and what does their story look like, and where do they need to be, and then how do we design the intervention to get them between those 2 points? And sometimes the answer might be they need to load heavy. We need to change the structure as well as getting them to reorganize their training and their acute versus chronic load, all of that stuff. But the other group may require a much more holistic approach where they need to work on their general health as well as load something like the cuff. But does it have to be at 85% of a 1RM for 4 by 6 reps? I'm not convinced that it does, and we know from the research that it probably doesn't. So I think that opens up the possibilities to clinicians to treat the patient in front of you and don't feel like you need to be very prescriptive with exactly what we're doing. It's about them and what they need to get back to, and how far away from that they are.
Yeah. I just talked to Peter Malieris actually, and years ago he said I think his phrase was common sense prevails. Like
Mm.
yeah, exactly. If you don't need to get back to high level sport, why is heavy isometrics the thing for tendons?
Yeah, yeah.
Anyways, you covered a lot of metabolic, autoimmune, inflammatory stuff. I'm sure there are a ton more questions I could have, but we're at an hour. Tell everyone where to find you.
So I suppose I'm generally most active on X, formerly Twitter, at Derek Griffin 86. And in more recent months, I'm trying to do a little bit more work via Instagram. There's lots of good resources out there, Jake, like the stuff that you're putting out. And I think I learn from clinicians every day, I learn from clinicians that are seeing different cohorts than me. So like while most of my work is in like the persistent pain groups, I still see athletic populations. I still see a broad range of clients because I don't want to lose my skills in these other areas. I need to keep I think it's a very good thing to have a broad skill set across various areas, and you can still have your specialities, but the more kind of satellite knowledge I have, it has always helped me in situations where it's just a little bit more complex than I'd be expected. So I think Instagram, again, people like yourself, there's always good content out there. I see different ways of doing things. I hear different perspectives. As time has moved on, I think we many of us will achieve the same outcomes via different routes. And that's probably because we're ultimately targeting similar mediators of change, whatever those mediators are. We mightn't be fully aware of yet because the research is only developing, but there's probably many ways to do it. And, there might be some instances where we have to be very specific and very, when we're trying to achieve a very specific goal. But as you alluded to with Pete Malliaris earlier, it's about using that common sense and saying, well, look, what does this patient need? Do they really need to be able to do a single leg pogo really well? Maybe not, so don't throw the recipe books away, treat the person in front of you and learn from as many people as you can. Some of it will be good. Some of it you need to be a little bit more skeptical and critical of in a good way. Always ask questions. None of us have all the answers. I think we're very much aware that we're all learning. Yeah, and I think your recent podcast, particularly on tendons, you've had a wide range of experts on tendons. I'm far from an expert on tendons. You've had some of the real leaders in the field, and I think when we apply the work that they've done in the broader context of the research that we have on pain, then we can better our outcomes. So I suppose, yeah, learn from as many people as you can, learn from people that have different opinions and work in slightly different areas, because it will definitely help you. If you don't know about these things, you're not going to ask about them, and if you don't ask about them, you'll never know that you are actually seeing them. So I think most people that think they mightn't be seeing this group of people probably are, you know, different percentages in different settings, but you know, we all are seeing these subgroups, whether we realize it or not. So yeah.
Yeah, no, for sure. No, I had to get you on because the metabolic, it's just an area that's like kind of new to me. And I'm like, I can't see many people out there talking about it, but I've seen you talk about it quite a bit. So I'm sure you're going to be flooded with questions, more questions after this. But
Yeah,
um,
all good, all good.
yeah, Derek, thanks for coming on.
No, a pleasure. Thanks for having me.